Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Cigarette Smoking and Pancreatic Cancer Survival by Juan et al. My name is Autumn McCree, and I am an Associate Professor of Medicine at the University of North Carolina in Chapel Hill. My oncologic specialty is medical oncology with a focus on gastrointestinal malignancies. Pancreatic cancer is an aggressive malignancy with poor survival rates. It remains the third leading cause of cancer-related death, with life expectancies of approximately 1 year in those diagnosed with advanced stages of disease. Cigarette smoking is a known risk factor for developing pancreatic cancer, with upwards of an 80% increased risk. Measuring levels of circulating plasma cotinine, a nicotine metabolite, has been validated in prior studies as a more objective means of defining a current cigarette smoker. This study by Juan et al. Uses both questionnaire data as well as plasma cotinine levels to evaluate prospectively the association between cigarette smoking and survival in patients diagnosed with pancreatic cancer. The authors drew their data from 4 large cohort studies in the United States, including the Health Professionals Follow-Up Study, the Nurses' Health Study, the Physicians' Health Study, and the Women's Health Initiative Observational Study. The authors identified approximately 1,000 incident cases of pancreatic cancer in whom smoking status was available. Additionally, 485 cases with measured plasma cotinine levels were included from all 4 cohorts. Baseline questionnaires capture data on cumulative smoking history, as well as the relationship between primary exposure and diagnosis of pancreatic cancer. Cox proportional hazard ratios were used to determine an association between cigarette smoking and overall survival in these patients. Multivariate analysis accounted for potential confounders, including age, race, body mass index, diabetes status, cancer stage, year of diagnosis, and alcohol use. The authors used a validated cotinine cutoff level of 3.1 nanograms per milliliter to define current smokers. Of the 1,037 patients with pancreatic cancer included in this prospective analysis, the majority were metastatic at the time of diagnosis, with approximately 20% with resectable disease and about 15% with locally advanced disease. Median survival obviously differed based on stage at diagnosis, with metastatic patients living on average for 3 months compared to 19 months for those with local disease only. Regardless of stage, however, the authors concluded that current smokers had reduced survival compared to never smokers with a hazard ratio for death of 1.37. This was statistically significant with a p-value of 0.003. There was no confounding impact of BMI, diabetes, or other comorbidities via multivariate analysis. Additionally, a statistically significant negative trend in survival was observed with increasing pack years of smoking. For instance, those with 1 to 30 pack years of exposure had a 25% increased risk of death, compared to those with more than 60 pack years, in which an almost 50% increased risk of death was reported. Interestingly, former smokers showed no increased risk of death compared to never smokers with a hazard ratio of 0.99. Similar outcomes were also reported when pre-diagnostic levels of cotinine were used to more objectively define cigarette smoking with a hazard ratio of 1.76 in heavy smokers compared to those never smokers with cotinine levels less than 3.1. Differences in absolute survival were noted as well, with heavy smokers having a median overall survival of 4 months compared to 7 months in the never smoking population. The authors touch briefly on potential biologic mechanisms that may explain the reduced survival of patients who smoke with pancreatic cancer, including the direct augmenting effects of nicotine on cancer cell growth, as well as altered crosstalk between the tumor and stroma and an impact on the peritumoral immune milieu. The direct tumorigenic effects of nicotine have been previously published in preclinical pancreatic cancer models including a study by Delito et al. That showed nicotine treatment of a patient-derived pancreatic cancer xenograft model led to increased c-Met activation, a pathway associated with cancer invasion and chemoresistance. Interestingly, in this same study, evaluation of resected human pancreatic cancer samples for c-Met activity found that higher levels of phosphorylated Met correlated with decreased overall survival. Additionally, a link has been described between cigarette smoking and upregulation of circulating myeloid-derived suppressor cells, or MDSCs, a cell population that has been implicated in decreasing cell-mediated anti-tumor activity in preclinical models of pancreatic cancer. Kumar et al. Used a KRAS-driven genetically engineered mouse model of pancreatic cancer to demonstrate that exposure to cigarette smoke also increased MDSC differentiation to M2 tumor-associated macrophages, which in pancreatic cancer are known to suppress anti-tumor immunity and are associated with worse outcomes. In summary, this well-executed evaluation of how cigarette smoking impacts survival in pancreatic cancer patients using 4 large prospective U.S. cohorts demonstrates a 40% increased risk of death in patients who smoke compared to never smokers. This finding remains significant after accounting for potential confounders, including a propensity comorbidity score. There is a negative trend in survival associated with higher cumulative pack years of smoking. Additionally, an objective measure of cigarette smoking, plasma cotinine levels, showed reduced survival with higher cotinine levels. Perhaps the greatest impact of the study, however, is the reassuring result that patients with a former history of cigarette smoking but had quit prior to their diagnosis had no elevated increased risk of death, similar to the never smoking population. There was also no relationship between survival and the amount of time that elapsed between the quit date and the pancreatic cancer diagnosis. In other words, patients who had discontinued smoking within the past 5 years enjoyed a similar benefit to those who had quit more than 10 years prior. According to the U.S. Department of Health and Human Services, approximately 15% of all adults smoke in the U.S., with cigarette smoking contributing to over 480,000 deaths per year. Therefore, this study provides a strong rationale for ongoing smoking cessation efforts as a means of both decreasing incident cases of pancreatic cancer, but also, more importantly, decreasing the mortality of patients already diagnosed with this aggressive disease. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.